Okay, so you have a 5-year-old girl coming to you, and she has big breasts, pubic hair, and has acne. What do you do next? Well, this is a pretty classic case of precocious puberty. So, precocious puberty basically means you're going to have puberty before you're supposed to have it, right? So, in terms of defining when it is, a girl less than 8 years old developing breast masses, or a boy less than 9 years old developing enlarged testicles. So these are signs of precocious puberty, puberty before it's supposed to happen. So what do you do next? You want to make sure, logically, if this is a systemic problem. Because if it's an isolated case, then, there's always reasons why you could get bigger breasts, bigger balls, acne. You want to see if it's systemic. So what you want to do is do a bone scan, bone age test. This way, you'll know that is your bone age keeping up with your chronological age or not. Because bone age is dependent on your hormones, and your hormones are testosterone and estrogen. And if your hormones are out of whack, then your bone age is out of whack. You're going to have a bone age of 12 years old when you're like 5 years old. So, bone scan, bone age. Your bone age is normal with your chronological age, you're good. It's probably something isolated, no need to worry. But if your bone age says 12 years old and you're actually 5 years old, then some shit is going down. So, next step, what you want to do is LH serum level. Why do you want to do this? Well, thinking backwards, the problem is you're having some crazy ass growth spurt right now. You're hitting puberty way too early. Why are you doing this? Well, think about it. In males, puberty is due to testosterone. In females, puberty is due to estrogen. Where do these hormones come from? These hormones come from your gonads, ovaries, the granulosa cells in females, or the testicles, the Leydig cells in males. So if you're having growth, you're having puberty, obviously the testosterone and estrogen is going to be elevated. But what acts on these certain cells to elevate them? Well, it's luteinizing hormone, LH, which comes from your brain, the anterior pituitary, which is stimulated by gonadotropin-releasing hormone from your hypothalamus. Hypothalamus releases gonadotropin-releasing hormone, which acts on the pituitary, the anterior part, to release LH, which then goes to the female's ovaries to release estrogen, or the male's testicles to release testosterone and make you grow. So if you measure LH, depending on if it's high or low, you'll be able to tell if this is precocious puberty stemming from a central part or a peripheral part. Central being your brain, peripheral being your gonads or somewhere else. So let's think about it. If LH is extremely high, you got it, you're done. You know that LH can only be released from your anterior pituitary, so there must be some squeezing or some extra LH being released over here. And one of the few ways that it is released in excess is probably if you have some sort of tumor, like pituitary microadenoma, a craniopharyngioma, or any other brain disorder, brain cancer. So obviously you want to look at it, get an MRI, and see if what's going on. Now, if the case that your LH comes back low, you do have a few options to do here. What you want to think about is now you can either be central precocious puberty or peripheral precocious puberty. If you have low LH, you want to see, is your pituitary actually working? And if it is actually working, then your central precocious puberty comes back into play. You have low LH, so you give the person GnRH to see if the pituitary is actually working. I want to stimulate it and see, can it actually secrete out LH? And if it is working, and when I do give GnRH and it releases a lot of LH, then I got my answer. It's central precocious puberty. Again, get an MRI. But if I give GnRH when the LH was low, but the LH continues to be low, then something must be inhibiting the pituitary and the hypothalamus. It must be excess, tremendous amounts of both estrogen and testosterone, depending if you're a female or a male. And I know testosterone and estrogen are released from the gonads. So something must be triggering them to be being released in crazy amounts of numbers to cause negative inhibition on the pituitary as well as the hypothalamus. So in this case, with my diagnostic test, I'm thinking is more going to be geared towards peripheral precocious puberty. So in a female, I want to check out the ovaries, do an ultrasound of the ovaries, a pelvic abdominal ultrasound. And in males, I want to check out the testicles, see any masses, ultrasound the testicles, and see if there's any sort of tumor. Of course, if it's a testicular tumor, I'm thinking Leydig cell tumor because that releases a lot of testosterone. And if it's a female, I'm thinking granulosa cell tumor because that releases a lot of estrogen. So in any of these cases, what we're thinking is how we want to treat this. Because what's the big deal with precocious puberty? You're getting puberty before you're supposed to. You're supposed to get it in your teenage years, but here you're getting it before 9, 8 years old. The problem is you're going to develop this acne, you're going to go through these pubertal changes, and you're going to grow really tall early on. And this means that you're going to age faster. Your bone age is higher than your chronological age. The thing is, if your bone ages really fast, your growth plates are going to close. That's the end result of growth. Your growth plates close and you stop growing. But because you have puberty so early on, your growth plates are going to close faster than they should, and you're actually going to end up shorter than everybody else. You're not going to reach your maximum potentiated height. So what you want to do is slow down this precocious puberty and make sure that you're not having puberty so early. So, of course, you want to fix the main problem, which is too much LH, too much testosterone, too much estrogen. The way you do this is actually something sort of counterintuitive at first. You give a GnRH agonist. Yes, that's right, an agonist. So one of the GnRH agonists is called leuprolide. I know what you're thinking. You're thinking, I just said the GnRH goes from the hypothalamus, stimulates LH. LH is increased, which increases your gonads to secrete estrogen, testosterone, which is going to friggin' further exacerbate the problem, right? Well, there's a little caveat. GnRH, when it's released in a pulsatile form, like you're giving pulses, just like you give IV boluses and don't, and boluses and don't. If you give it in this way, the brain reacts by releasing a lot of LH, a lot of FSH. And this is what triggers puberty. But it's pretty cool to know that GnRH, if you don't give it in a pulsatile format and you give it in a constant stream of a dose that you're being given medicinally through oral means or anything, then it actually has a counterintuitive effect. It actually inhibits LH production. And this is what we want. If we give leuprolide in an oral form that's a continuous dose throughout childhood, then you're not going to have a lot of LH. You're not going to have a lot of testosterone or estrogen to do growth, and you're going to inhibit this early puberty to save it for later, thus fixing the problem.